Yeah, that's it.
Go.
So this is, they changed the number, that's the thing. A 76-year-old male who had a stable angina class 3 when he got a cardiac cath. Known diabetic, hypertension, hyperlipidemia. So cardiac cath had shown he had 3 vessel disease. And I'm going to show you, he had mild LV dysfunction. So if you can start seeing the angio first. So mild LV, but more important is, I think, the right coronary artery, if you see only it's a PDA, early bifurcation, but PDA had about 70-80% disease. But most important here, circumflex was a bifurcation lesion, and then LAD. Calcific, so mid LAD, after that I'd say moderate size diagonal, calcific was about, I would say, moderate diffuse. You can even call 70 to 80. So what they did, the IFR of the LAD was 0.75. RCA was only the main vessel IFR was 0.94. But either way, because diabetic and 3 vessel disease got a heart team discussion. But patient refused surgery. So what we did was we did the PCI of the circumflex. And today here he is for PCI of the LAD, calcific mid LAD, as well as the diagonal, which is about 90%. The plan would be that we will discuss with the panel how to go about this case. And other thing also same, we have the same panel. Earlier they did ask, why I was not doing radial in a bifurcation case. For this case, we have switched to radial. We have a left radial, 6 French.
Yeah.
Well, of course, we
Left radial.
should have known. We have Dr. Barman in the center of the screen. Can you,
Yes.
before we go into the discussion of the LAD, can you tell us what's the RCA plan? Or it's a diffuse disease and you don't plan to target it?
No,
we didn't see that very well.
RCA is just the PDA. I think we can leave it for medical therapy since IFR of the main vessel was 0.94.
Okay, very good. All right, so deferred to mostly non-physiologically significant, the RCA. Let's have some discussion. We'll take a look again at the LAD, and we'll have some discussion by the panel.
But look at the calcium in the LAD. Very tramp track again. And the diagonal does not have calcium, but
Right.
definitely LAD has.
So
And what
Waxman?
technique should be used, rotablation or orbital. In this particular case, we can have various points, but straightforward case, there is, if not angulated, it's basically is a dealer's choice, what you are comfortable with. So this case now, we are starting with the orbital, because we have done quite a bit of rotational. Of the 6 cases, 5 were rotational, 1 was orbital. This will be case number 7. So his score become 5 and 2.
I thought all the even cases are orbital and all the pair cases are rotational.
that would have been too easy to remember, but
Yeah.
so clearly advancing very slowly at the slow mode of this atherectomy device is very, very important. In fact, in this hospital, we never use a high scale of this device. Any ideas regarding selection of devices and experience with these 2 types of cases?
Would you, Dr.
Go ahead.
Would you think you would decide orbital if the extent of calcium is long, like a long calcified disease, as opposed to rhodo, because of the particle size being smaller?
I can, but we'll do on glide assist.
Is that a consideration? I basically use rhodo for everything,
Oh, jump.
rarely use orbital.
Just let it sit. Don't.
But there was some thought that for long disease segments, orbital is better.
No, I think if the angiographic, as we had discussion earlier, where it really going to work will be if you have circular arc of calcium. Question is many times you see a deep cuts and dissection with the orbital. And what we found is if there is a circular arc of calcium, then orbital works very well. Because what happened is because of the vertical motion beside to and fro, if there is a non-calcific arc, that junction of the calcific and non-calcific cause the dissection. And that is all. And second point is the 80,000 RPM. But I don't think the length issue will be any reason. It will be just the degree of calcium if you have done the imaging. But otherwise, like this kind of case, both will give you great results. If it gets a little tortuous, that LAD which I did on earlier with the bifurcation LAD diagonal, that tortuosity may give little trouble because of the stiffer 0.012 Viper wire. although the new Viper wire they are making may make change a little bit because of transition, but we still have our old Viper wire.
Yeah, this could be a good case for the EXCEED trial because you could have been randomized balloon versus orbital.
One of the factors, there's a big diagonal here and doesn't have much disease, so probably don't need to protect it. But lately, there have been some cases where you put a fine cross and a wire in a branch, if it's likely to be lost, just to protect it, even with atherectomy.
With orbital, you mean?
Yeah.
Yeah,
But
interesting.
going back to the LAD, I know the ostium probably is questionable, but definitely a 90% lesion about 15 millimeters further down. That needs to be addressed.
Yeah, so one thing that's always helpful is the imaging guided intervention. And again, for me, it doesn't matter whether you do OCT here or IVUS, but it gives you some more information about the degree of calcification, the ostial of the LAD, et cetera, et cetera.
Yeah, no, I agree. I think the left main and ostial LAD, there's so much diffuse disease. So two things about orbital atherectomy here is one, that, with rotational, if you go through that left main and proximal area, that I think it'll be hard to go. And orbital with glide assist, it goes down very, very nicely. So that's one. The other is because of the mechanism, you still have some blood flow around it, and especially when this left main, so you have probably theoretically less ischemic time. So I think orbital, probably work. And I agree. I think imaging to see that area and the left main is critical.
Well, I think the last comment speaks to the question we heard before, why there's a notion of perhaps a longer lesions. The orbital may have an edge. Maybe exactly what Dr. Singh just said, that have the blood flow around it and all that. So you may, if you have a prolonged case of ablation, that may be better tolerated, so to speak. You see now the rewiring with additional wires. Tell us a little bit about the basics of the radial PCI. Are you limited to 6 French with a radial, or is there ways that you could use a 7 French compatible system from radial aspects for a complex case like this one? And how would you do it?
Yeah,
Dr. Barman.
Barman.
Yeah, no, I mean, I'm having a little trouble hearing. I heard 6 or 7 here. Yeah, I mean, I think with the current tools, and obviously a bias towards provisional stenting, many times we don't. But when we need obviously for equipment reasons or strategy reasons like 2 stents, if the patient is of reasonable size, then I think with the slender sheath and
No, go ahead, you go ahead.
Yeah.
You cut it.
and balloon-assisted tracking and different techniques to track the guide, I think it's very feasible. In fact, we have another case, I think, later today of such a case, a 7 French guide from the wrist. But again, I think arguments against radial around support and strategy are less founded now, especially with the equipment, better stents and mother-daughter systems. Of course, all of the ACS data is in terms of benefit. It clearly shows a relationship in terms of experience, operator, and institution experience. Up again?
Yeah, so if you see that at the ostium, you definitely saw that there was a dent down.
Now, what size equipment is this you're
2.5,
using now?
2.5 cutting balloon.
Yeah, go again,
2.5
left, right.
Pass
No,
it.
no, no, it's not going to go.
George, they
There's
said
one
there's a
more
left radial.
It's a
They
left
said
radial.
Left
yeah.
radial, okay. Do you do distal or just a regular?
I mean, there was one data from the London PCI registry, Pan London, that radial, they showed that the outcomes of the radial rotablation was better than the femoral. But I think it always happens with the type of cases you are selecting and so. And now, even with the acute MI cases, the question always will
2.5,
come back that with the recent data that really going to show the major difference in terms of mortality or BMI, or even once you get a good in terms of the vascular complication, that using a micropuncture technique or some cases, ultrasound with the femoral, does it really make a difference at the center, which does 50-50 radial. So key is that we do about now around 40 plus, just reach 40 mark. Our goal towards the end would be to get to 50, but we'll remain around 50. And one of the things which we have learned and trying to analyze our own data, that once you have complex case, and complex will have a definition, calcific, bifurcation, so the complex case, does it take more radiation, more, and clearly what Anu always talk about, that you start doing those cases, you probably won't need an extra light at home. You'll be radiating yourself.
Yeah, well, I thought that Tuck had a comment regarding the left versus right radial. I think our experience here has been
Why
that
didn't you do the LED
maybe the left radial
Yeah.
engagement
Why
of
did
guide
you-
selections and catheters is a bit easier.
Good. So
And,
now the whole
we
purpose
figured
was
out
because
as
the
a
diagonal
default.
disease,
Yeah.
that in this particular
Easier,
case,
top,
they do
in
the
a short
DK crash
patient, actually.
with a 6 French, and
So what balloon we have in the LAD now?
There's a little dampening on the guide catheter. I don't know if there's some left main disease we don't realize.
Yeah,
Premier.
Yes.
I think it's a little bit of a
Okay.
deep guide catheter intubation in relation to the access
But
side.
I wish we have a trial comparing rota and orbital. We actually working with the Boston Scientific, because clearly, as you know, the Eclipse, one arm is the orbital, but the second arm is anything except rotational atherectomy. So, and then clearly that we definitely in this day and age, when these two techniques are available, we are trying to work out a comparative trial, maybe not large number of patients, but make
What's
it
the
more
strength
for
for the
acute
diag?
point of view, you
2518,
comparing
right?
rota and versus
18?
orbital.
But you know what's going to change a lot is, I think, the shock wave.
This is 3 or
There
20?
is
This is
definitely
3 or
going to
20,
change
yeah.
because
3
it
or
does
20.
give you a different
Lesion
dimension
opened up
to
very
take
nicely.
care of
That is what the
calcified
big
lesions.
advantage we have seen with the orbital also, that once even it looks like that may not have done the job, but it has done the job inside by cracking the, interrupting that interelastic lamina, so your subsequent balloon will expand it.
Right.
Like,
Yeah,
black
Dr. Sama,
modification.
This
Why-
is a 3020 or 27520?
3020.
yep.
We went
3020
up to
high
20
pressure balloon.
atmospheres.
Dr. Sharma, why you don't using high speed again? You say you're already using high speed, or George, you said that?
Very slow. You go very
During
slow.
our initial experience in the OA with high speed, we did have a few perforations. So since then, we have stopped using. And I think we mentioned it in the earlier cases also.
Yeah.
How would you select OA versus RA? Because this is the question that keeps coming back. Like Dr. Ron Waxman mentioned, whether you do OCT or IVUS, I think if you know you have more than 2 quadrants, closer to 3 quadrants if you have, then that's the time you definitely can select OA. But if you have less than 2 quadrants, or even 1 quadrant where you're definitely not going to do atherectomy, you got to be careful using OA.
That's the old.
And this is what we showed in our paper that came out in CCI, where we did a lot of imaging, both RA versus OA. And what we showed was same. The cuts are deeper. And what we found, why they become deep, is that when there is no calcium,
Right.
I think this orbital atherectomy gets
It
shifted towards the
it selectively disrupts the non-calcific
disrupt the
area, so that's why
non-calcific
you got to
vessel,
be.
especially if there is lipid. And that becomes a very deep cut, and that could result.
supposed to say that.
That was the old decision-making of when to use roto at all, was the arcs of calcium. And you really had to get a big degree before you started using roto. Greater than 180.
Yeah, I think the point of not using 120 speed is critical in coronaries. It really is. And if you look at engineering as to how it orbits, it actually gets better
What size?
effective cut
225.
with low speed and slow advancement
Yeah.
than with high speed. And high speed is associated with a lot of complications. So we actually also, at our institution, never use high speed.
Yeah, the argument is not only the safety aspect, that also, as Jazz says, that there's also, you really don't need it efficacy-wise. You just need to do a few more at a slower pace. Any other input regarding burrs and types and sizes?
Why is it
Dr. Lal?
that the original rotablator doesn't cut the non-calcified plaque and the orbital cuts the calcified
It's
and
called,
the
differential
non-calcified?
cutting.
Why is there differential cutting with the orbital, no differential cutting with the orbital? Why is it that cuts the normal artery while as the atherectomy doesn't cut? So what is the technological?
Because the rotoblader's diamond chips are only in the front.
No, because it's force is longitudinal.
not
I wish
right.
they can show a
Plus, it
factoid
doesn't wobble.
picture how
Yeah,
the
if you
two
see the
things
picture,
work,
it's demonstrating very well how it works.
how it works. F is equal to mc squared. That's what they have there, based on the force. Yeah,
It's
the
dancing-
orbital force. That
dancing
is
on the
why
calcium,
they put the higher. That means when your radius becomes bigger, the force becomes bigger, so it can be used in a larger vessel.
What is your strategy for the bifurcation? It looks like a tap or
Now
some...
this one we are doing a DK crush. It's the same
crush.
thing. You see that you have like close to 2 millimeters in the main vessel. Are they showing the Bifurcaid app?
Yeah, they are, but please just be a little careful now with the device sizes because we're a little distracted with the atherectomy
Okay, 2 to
catheters
5,
and all
let's
that.
go.
So you're using what stent? 25,
So
20,
this is
20,
no, yeah,
28, 23?
20 in the diagonal, and then we have this
25,
balloon
20.
already, which is a 3O, the same balloon that we had in the main vessel, which we used to pre-dilate, the same thing. So this is what we are going to do. We went up, we did a nice, so I'll take the SDS, and what we'll do is I'll take out the wire. Oh, you wanted okay, you want something else. Okay, I'm going to take out the wire and then you crush it.
The
So you
ostium of
crush
the
it with a 3O balloon?
Yeah, now this is a 3O balloon. Crush it, go.
The ostium of the LAD look funny, I think, imaging, I agree with Ron, I think imaging before doing the bifurcation stenting, may have helped
Go,
us here.
real high pressure.
Yeah, even the
Well, the
wiring of
lesion
the
is so
ostium was
long
difficult.
Okay,
that
good.
the lesion is so long
Down.
that I also favor the strategy to take care of the distal part and by including the bifurcation, and then whether you want to need to add up a stent proximally to the ostium or not, you decide at that time. I think it's this way we have a stepped approach and we don't have to tackle any question, all the question at the same time.
Now, what balloon you have?
So right
202?
now the stent has been delivered 3020.
I know.
2528.
2520 in the side branch, and there was a 3020 balloon in the main branch that after removing the equipment from the side branch, you inflated in order to crush the few struts that are still sticking out in the main vessel. Now the next task of this procedure is that you need to advance a wire into the side branch through the minorly crushed stent that was just implanted. Let's see how that goes. And you can see the app at the left side up top there, that how it works out.
And what wire do you use for recrossing the diagonal?
So this, we had a fielder. I think that's what we always say, a polymer coated wire. I know a lot of people are worried about leaving this in the side branch, but it's easy to recross.
So in the fielder, you
But I
have
think
fielder and
what has
fielder
happened is the
FC.
tip is all botched up now.
Do you use the fielder or the fielder FC?
This is fielder, regular fielder.
Regular fielder.
Okay.
It is easier to recourse it when you do a part. When you do a part of the proximal optimization before the diagonal, the crush, then I think the chance are much easier to recourse.
Why would you pot, what is pot? For
Proximal
when you're not
optimization.
stenting.
Optimization.
Yeah, I
to the
know, but why
stent.
would you do it without stenting? We already dilated it.
No, not now.
They're not talking,
Probably
we're
at the
just
end.
having
When you
general
re-
discussion there, but you select a better wire now, get a new
We
wire
already finished the procedure
in order
with both.
to cross that.
Yeah, that's the plan.
One thing here is that sometimes people try to pull the stand not too far back into the main vessel and they may miss the ostium, so it's a good thing to have some overlap into the main vessel. And the other great technique is that you have the balloon right there, because sometimes you deliver the stand and the balloon doesn't go anymore, the main vessel balloon. So that's a great technique where you have it parked there and then you're ready to crash.
There's truly something happening at the ostium LAD, there's no
I think
question.
we're going to post dilate now.
And the twin
Maybe
pass
the
is
waves
another
go-
option
yeah,
here.
Some
for
specule of
recrossing.
calcium, right?
I would take a picture.
Okay.
Yeah.
This is why we showed the mini crush before. Go up. Multiple steps, go.
So now we're crushing it again. Now we're crushing with the distal part of the balloon in order to
Down.
have a full balloon inflation in the proximal part of the vessel. Well, distally, we're going with a 38 stent. The lesion extends quite distally from this takeoff of the diagonal.
I can tell you
So
it
you're
may be
really
because
looking
this
into
stupid balloon is in the-
into a distal stent.
Take the balloon out.
Take that thing up.
Clearly, it's
Most
not
easy
a
for the
it's
crop
not a very
pieces.
encouraging sign that all these wires have such difficulty to go through and through the proximal part, because you really got to have an avenue to go your equipment in and out.
I would just give a little dye there and see what's going on.
Okay.
It's nothing there. Bad guys.
Guide dissection, yep.
So
Okay,
you just have
I'm
to be
good with the
careful
wire.
there.
Yeah.
You wanna stent
You may
across
have
the
bended the
circ
tip of the wire. You may want a
Stent
fresh
across the
wire.
circ and then-
So
I
this
think you
actually,
need to put a guide
I
back
think they have a
slightly.
dissection there,
a
that you have to
twin pass
really
is
wire
there
that
much
Some
carefully.
to avoid
visualization.
going under.
Here, take this.
Yeah, it looks like a tear in the ostium, actually.
So that's usually the problem when the wire consistently goes that.
Back it out. Back it out a little, please.
I think so. It's okay.
It's actually a tear in the left main.
Extending into the left.
And more in the proximal LAD.
Yes.
I
More of
wonder
the
if it's.
proximal.
So it looks like it's
I wonder if it's
extending
also
into the-
related to the deep guide catheter positioning that we see here, but we can see a little bit more about that.
Maybe placing a wire in the circ now may be a good time.
Yeah,
Yeah. And make sure
so you have control.
you have, so it doesn't start clotting off.
So what pharmacology are we using in this case? I presume the patient is on ticagrelor and aspirin
go,
based on the
injecting
fact that has all stents. Is that
Proxel
So
LED.
it is
Is
just
that the-
prox LAD, nothing in the left main.
nothing?
We can still use
Go to the
more
LAD
stents here.
diagonal, yeah. The patient is on antiplatelet therapy. Patient actually originally, after the intervention of the circumflex was on clopidogrel, 76-year-old. You can always think about adding a more potent agent now.
Are you going to wire the circ? Yeah.
So he is on clopidogrel right now, or
Run
ticagrelor?
through?
Patient is on clopidogrel.
Maybe pulling the guide back a little bit more. There
Yeah,
you go.
that's what we are doing, yes.
No, if you pull the guide back, then you have no support. Hold on.
Yeah, that's better right that position.
See? You see that? It just
got it,
does
yeah.
not stay.
I think you need to have a little bit of a
No,
more
different
permissive.
curve.
We need
Different
to make a
curve.
little curve there. The
Lead-
wire is, yeah,
Yeah.
a matter of a curve. The wire
Now
is
go
too
to
straight.
epithelium, right?
Yeah, but I would switch the wire.
You
won't
plan
get
you're
it
in
there.
if you're not
This patient.
extending that dissection.
The question is now, do
Yeah.
you switch the wire, or we try even this wire still?
And the balloon support with this wire, but
Get a small balloon.
yeah, we have it.
My favorite wire is Fielder FC in situations.
Okay.
It
We're gonna
looks
have to
very
pull it
good.
again, so.
All right, so the wire has gone through the strut of the minorly crushed stent,
Yeah.
and now we're going to perform the first kiss.
What balloon you are using now?
Yeah, we took the other balloon out, the LED balloon out.
Yeah.
Sometimes your
It's a
first-
2012.
Sometimes your first kiss comes later than you expect.
Now, might you want to stand the middle AD before you finish the bifurcation so you don't have issues delivering the...
You want to put the 3O balloon in?
Yeah, get the 3O balloon.
Actually, once you do the mid, we'll use a 38 millimeter.
I'm gonna do this in the-
Probably
the
will
2.5.
come up to
We'll
the
be able
ostium
we'll be
there.
able to deliver that. I'm gonna go up there.
Give me.
Yeah, that was a question we're having
Yeah.
here, actually, because it looks like the disease in the middle AD is very
Get the
long.
2.5,
Yeah.
12
The-
high pressure.
There's question whether the 38 may even cover and doesn't even reach the ostium, but we'll find out.
Yeah.
But
2.5, 12 high pressure.
there could be a strategy that you
15, yeah.
use perhaps a
have that?
33 or something. You
Oh, yeah,
finish
yeah,
off with a long stent in the distal LAD, and then you have a shorter and perhaps even bigger stent for the bifurcation area.
Just get going.
Because anyhow, you're reaching you're dealing with two stents here for this total length of the LAD lesion.
You know, that was an old concept to
the
always
awesome
stent
stent to
distally and come
distal
back
and second.
proximally, but I think the equipment's so good now to stent proximally here, take care of this dissection, and then work, you know, a little bit more with less anxiety going through the thing onto the mid portion, because you can deliver pretty much anything now the way the equipment is.
I mean, so far, hemodynamically, patient is doing fine. Good blood pressure.
Yeah, we can
and
see
with
that.
Always
Great.
good. Our high blood pressure is good friend during PCI.
I mean, that is what we had planned. I think I agree, we take care of the proximal LED, but first, uh-oh,
Yeah, good. Let's deliver the LED balloon first.
no, this one is LED.
So trying to do still the optimal first kiss.
Keep working.
So you're using what balloon you're using now? What
Now
are the
this
two
is a
balloons?
2.5 high pressure balloon.
For the
In the-
diagonal.
2, 5,
diagonal.
12 high pressure balloon, and what else?
3O, 20 high pressure
Original balloon.
in the original balloon of the LED.
You want to post.
So we're going to do the first kiss with the 2-5 high pressure balloon in the diagonal and the 3-0 high pressure balloon in the LAD. You don't want to inflate that balloon in the diagonal a little bit more distally and then come to the ostium once you have
we
it
can
anyhow.
track it
Then?
into. Here.
Yeah.
Yeah, we may have to do that.
You do a little optimization of the stent.
I think another point is definitely not to open the ostium before delivering this main vessel balloon.
Okay, good. Wait, I'm going to go in with the diagonal.
Yeah, and then I'll anchor it. We have to dilate the
Yeah,
distal
watch the
half
wire,
of
though.
stent anyways here.
Okay, go.
You put your wire in a little bit or no?
Yeah.
And also, one of the reason people talk about the decay crash will take you 6 French is needed. I showed you the case which I did LE diagonal. If your stent sizes are less than 3 millimeter,
Give me a new
most of the
balloon.
guide will accommodate
New balloon.
New 3.0.
stents.
15 high pressure.
But once you get to 3
No
millimeter
need a high
plus,
pressure.
then you don't need with a 6 French will not accommodate.
That's an interesting tip. So if you're working with a 275 and 25 stents,
You will go through 6 French.
you use a 6 French, you don't need to go to complex,
Yeah.
more complex access radially.
Yes.
That's great. Dr. Barman, is a left radial the default strategy at Mount Sinai or depends on operator?
No, depends on the operator
yeah.
and also age. I think elderly patient left probably better. And between the left and the right, I definitely think left probably behaves more like a femoral, since
sure.
all our
And
guides are
since we,
femoral shaped. It's
Since
much
we got
better.
since we got a little better left radial system, we've done more, but certainly we use age, height, patient height, obviously the presence of an in situ lima, or some other reason to spare the right arm.
If the patient have a big belly, it's very hard, I mean, to put
Yeah,
the
that's
head.
Totally
true.
agree,
So
yeah.
I think you
Agree.
have to take
Well,
into
yes
account.
and no, because you have a dedicated system that supports the left
No, what he's
elbow
saying is that the
and
arm
keeps
of
the
the
arm a little
patient.
bit
Lean
better.
all over the,
It'll kill your back,
And-
it really will,
Well, 6.
you know, with big patients.
I mean,
And
if he has a
the-
big belly and a short hand, it's going to be hard.
3.038
Well, there are
first
too
from
many
the osteum.
complications. Now, not only have a big belly and have a short hand.
Well, that's the metabolic syndrome, right?
Okay, 3038 now, we'll go with the 3038 in the LAD, like everybody mentioned. We'll take care of the proximal part of the LAD first, and we can do a stent, distal stent later.
So anyone want to tell me why this step was important right now? Why can't we do directly with the stent? Because we already did the first crush with the balloon in the LAD.
No,
Why this step is
The
important?
purpose of this step is to facilitate the next crossing with a wire, because then after you have to recross with a wire, and that
save these
recrossing
balloons,
may
because
be
those
tougher
close ones.
without this step. That is
So just for recrossing.
that's it, yeah.
You're correcting the deformation actually, so, you know, I have a sort of a simpler
not at the
technique
mark
of
level.
decay cross that is, because, you know, you really have deformation and it's axial and longitudinal deformation, so you correct that before you recross. So that's what this step does.
So you can do kissing balloon in about
There's
80% of
one
crush.
major thing for do a good final kissing if you
Okay.
do
It's a
first
It needs to
kissing.
come out anyways.
But I think another advantage,
good, all
the
right.
side branch stand, when you do the first kissing, you get more optimus dilated. The minimum surface areas are much better than you do a classical crush.
Yeah. No, but clearly,
We agree with
optimize
all
the
these suggestions, but I can tell you with mini crush, we would be in the next case by now. That's
Maybe on the
one.
third
And number
case.
two is the same. There's never been head-to-head comparison between mini crush versus DK crush.
I totally agree with you. I
Yeah.
think that we should challenge this because this is so much work and so
You
many
have seen that,
steps.
so much work, and
And I'm not sure about the
Radiation.
utility of that. Definitely not if it's not a left vein.
yeah.
You know, radial-wise, I think the sheetless guide would be great here. Actually, it's the same size hole in the radial, and the sheetless guides are very nice for bifurcations like that.
I don't know if you tried the balloon to go or not.
All right, so let's see how the delivery of the 38 stent is going to work out here. That's what Dr. Brelakis was alluding to, that because the stent is very long, whether you would
Put it immediately before the.
deliver it before the strut. I employ the body wire technique now.
And you have an extra wire in the
You have
diagonal.
to
You don't
pull
need
that
it
wire
anymore.
anyways here.
okay, good. So body wire helped us
Yeah.
connect. So now we'll go caudal to make sure we are up to the ostium.
Make sure you pull the body
And I'll
wire.
pull the body wire out.
Don't forget pulling the body wire.
And I'm sure the tip is gone again. Okay, ready?
We use another new wire of those.
Yeah.
Ready, Cindy?
So
It's a promise, right, guys?
Yes.
So you're at the ostium. You're covering.
I think I pulled back a little bit. We are not up to the ostium.
So that was the original question that
Good.
Yeah.
Dr. Brelakis was posing, because we would be standing around here.
The two oblong
Should we
guys.
have gone right away with
Actually, let's do the
with a
distal
stent
stent
distally?
Down.
So this step is our final step in the stenting quest inside this vessel.
Yeah, this is
Clearly that has a choice. Perhaps we could have put a 33 stent down below first. So this time we just overlapping with the original stent.
You know, a lot of times it's nice to take a cine there and maybe even two views just to line that up a little bit. I know you have a feel for where it is, and it looks like you got it.
But this is where I really think that use of IVUS to mark where your true ostium is and staying in that view, either it's co-registration or whatever you do, is critical. Really, it makes you place the stent precisely.
Yeah, very good points as well, because, you know, we want to bring that stent all the way in the ostium, so have a very good result when you deliver either a 28 or
2.5, right?
maybe a 2
We are going to put a 2.538 distally now, and then we'll do the final kiss.
2.5 or 2.75?
That's a big distal vessel.
It's
no?
2.7538
bigger than you
Promus.
think.
Yeah, 275.
You make it bigger, made it bigger. It wasn't as big, but
We underfilled it there. too.
after all the ballooning and the atherectomy, it
start there?
becomes much better. Then when I employ again the body wire technique,
I just want to see this balloon will go. You want to post dilate here?
I think it will. A few balloons, yeah.
Huh?
It'll go.
We will have
This
to go
balloon,
on
sure.
the fielder.
You guys planning to
Why
image
don't you
this?
take a fresh balloon?
Just
We
fine.
will
Get
image
the
at the
IVUS
end.
ready in the end. Yeah, we'll do it.
So I think
Right.
what we'll do is we'll place a long stent distally and we'll kiss, and
you wanna
that
go
should
over
be the
and
end of the
then,
case.
yeah.
Yeah, we start.
Yeah, okay.
We'll move on to the next case, which would be the tower valve in valve now.
2.7538.
all right, and then
Very nice.
we can move on to the other room, and then we'll come back shortly here to see the final result and the IVUS, I suppose. Huh?
We'll
Or
just
don't
have a
forget.
few more minute discussion till we get ready in that room.
Oh, okay,
And
very
you
good.
can see just about 2-3 more. But look at the long, long lesion in this particular case. The entire LAD is so diseased.
Yeah, it is long.
Gets to be a very big vessel by that apex.
Are you planning to perhaps test the patient for the Plavix resistance? I would be a little concerned with so much calcium, long lesions, so many stents. I would like this patient optimized.
100%.
I think that would not be a bad idea.
Patient
so much
76
stuff
years
here.
of age, I'll just give a Brilenta.
Yeah,
I would actually give this patient now Kengalor to get me through the procedure safe.
right.
Yeah.
And after that, we can do anything that you want to switch. But that when you give Kengalor through the procedure, you know you don't have any questions about anything. And the switch on, switch off, 4 minutes, it's very tempting.
Right about that. There's clearly that would be an option as well, because delivering all these stents with all these equipments through a 6-French guide, multiple steps, you may have a
You don't wanna
risk
have
for
any troubles
intra-procedure
build up, yeah.
on the procedure events, and you try to exactly avert them as Dr. Waxman
along
pointed
the
out. And you can see how the stents deliver well, but again, it's so calcific diffusely that there needs to be a lot of post-dilation to a good level here.
So you can say anything that you want on the radial here, but I think it would be much easier to do it from the femoral.
I 100% agree.
I disagree.
100% agree.
All right, we heard from,
Thank you, Samit.
Let's
I guess
hear
I'll
from
abst- I guess I'll abstain.
let's hear from Dr. Barman. Would be as easy to do from the right radial?
Respectfully abstain.
He's abstain, okay?
But radio, they
He's
don't
gonna wait
call
till
you
the
at
end of the
nighttime for
procedure, but-
hematoma. Come on.
You have to add the closure time and the hematoma compression time. Here,
And radiation time and contrast time
want to take a picture? Just
And
for
dissection time.
and dissection of the
We'll have a
left
little
hand.
proximal dissection time as well.
Yeah.
You see, ever since we put in the stent, ever since the guide is positioned in the LAD, the pressure is ventricularized.
Yeah.
So
He,
there may
he
be
does have a 100 millimeter pulse pressure on a non-invasive too, but I agree. Obviously, there's disease there, and the dissection kind of confirms that, I think.
All right, so now this is a step that all this work has been aiming to facilitate, the recrossing of the wire into the crush stent. And you see that it was rather easy.
Very easy.
So there you go, Ron. That's why we did the first
Just
kiss.
30,
Should you image the LAD if you need any more stents distally?
Yeah, so we have 3020 and this is 2.5.
no, this is the 2.0.
Oh, it's a
Yeah,
2.0.
yeah, yeah.
Okay.
And then get the 2.5 high pressure balloon guards.
Yeah.
And you plan again the kiss with the same equipment, 2530?
Yep,
Yeah,
and then
two
2.5 and 2.
non-compliance,
Yeah.
yeah.
And the 2.0 first compliant, then 2.5. Non-compliant, which we already have. And just to, we have seen, maybe we should show one picture and then go to room 6.
And you're going to end with a pot, right?
Go
Yeah.
up on the 2.0. Go up. 20.
Yeah, let's dilate this stent all the way, the distal
Yeah,
part
we'll
of the stent very well.
Yeah.
Oh,
We
is it
need to
down
do
then?
more distal inflations.
Down.
Yep.
years more. That's just.
After all this work, I'd love to see an IVUS image of this thing.
Yeah.
It's going to be a long one.
First.
I want to make you review every single frame of it. At 0.5 millimeters per second. No manual pullback here.
And are they ready in room 6 yet for valve and valve tower or no?
Well, we hope they are, because you're finishing up your
didn't get that down.
intervention very swiftly here.
I should have went down when it was new.
And what
Are
is
they
the,
ready?
what
Okay.
is the current thought regarding heparin or bilirubin in radial procedures?
Not yet. I'll tell you after this picture.
Get the
We'll go.
2.5. Come in 2.5.
Well, the
Well,
matrix
we-
study showed that the bivalirudin doesn't add much. Right?
Yeah, I think for in a lot of cases via the radial, perhaps including this case, the strategy is the heparin in combination, whether or not you combine it with any other antiplatelet agent, that's a different story, but it's mostly that way.
You know, we tend to give a radial flush with heparin in it, get a quick ACT, you know, you give, just follow an ACT once or twice. It makes it a frugal way to do these things.
Yeah.
Makes it-
Plus, if you have a lot of hardware and you're in there for a long time, bivalirudin is associated with thrombosis. Remember the Bifurcaid days? They used to have these indwelling things, so the mechanism doesn't really work. So I think,
I don't remember when was the last time that we used bivalirudin.
down.
It's
Yeah.
been
Right.
completely wiped out from the shelf, and there is no need for that anymore.
I tell you, the heparin's also great when you're doing acute MIs, just to get serial ACTs. We get one
All
almost
right.
every 5 minutes.
Let's do
and
now
you're
the
seeing it.
second kiss with the 3.0 and the 2.5
Yes.
at
Both
10
high
atmospheres or so.
As the thrombus is going away, it just eats up the heparin.
Actually, in this case, we can give IV cangrelor. Why don't you order it? Yeah.
I thought they're giving it already.
No, it was not. We trying to give the ticagrelor, but not IV cangrelor. So I think we should do it now.
Yeah, if you do it, you should do it now, not
Now,
because at
yep.
the end of the procedure. And
Yeah,
the switch
exactly.
would be to ticagrelor.
I mean, obviously, if you want to decide to do it, we'll be better to do it in the beginning, but at least we haven't finished anyhow.
Yeah. Let's take a picture, then they are ready to go in room 6.
But maybe because the IVUS run is going to be so long, as Dr. Singh wants, maybe we need to have the cangrelor, make sure we don't have any thrombosis during this very long and very slow IVUS run for optimal visualization.
All right. Looking good.
Very
You're
good.
ready to go to room 6 now.